All right, I think we'll get started. Um, I guess Happy New Year, everyone. This is so I'm Rhoda Plakogiannis. I'm the NELA president, and also on behalf of the NELA Board of Directors, we are excited to kick off our first NELA night for 2024. Also excited to announce that participants of NELA nights going forward will be receiving CME credit. So if you look, before I forget some housekeeping, please look at the chat box. You will, or shortly after, you'll see no, it's there. It's posted a Survey Monkey. If you could complete that either after the session, and certainly just get that done in order to claim your CME credits. So with no, also please don't forget, if you have any questions, please put them in the chat box and we'll address them as Dr. Saseen goes through his presentation. So with no further delay, it gives me great pleasure to introduce Dr. Saseen. For most of you, I'm sure you're very familiar with Dr. Saseen. He is an Associate Dean for Clinical Affairs and Professor of Clinical Pharmacy and a Professor of Family Medicine at the University of Colorado Anschutz Medical Campus. He is a clinical pharmacist and focuses on cardiovascular risk reduction and population health, and his scholarly work includes almost 200 peer-reviewed publications and book chapters. Dr. Saseen is a past president of MNLA. He is a fellow of the American College of Clinical Pharmacy, American Society of Health System Pharmacists, American Pharmacists Association, American Heart Association, and he is a master of MNLA. Dr. Saseen, thank you so much for being with us today. So we're excited to get going.
Well, great. Thank you so much for having me. I'm Dr. Plakogiannis. It's a pleasure. I see some familiar faces here. So this is a presentation that I enjoy delivering. It's talking about statin therapy, of which I'm a huge advocate, but I realize that statin intolerance, something that I call statin defiance, and even the nocebo effect are out there. And my question is, does it really matter? That's my goal, is to go over these different topics. I have only one financial disclosure, but it doesn't relate to the topic of statin therapy. I'm on the Lipid monitoring board for 2 large outcome trials that Amgen is ongoing, their CV outcome trials, so it doesn't relate to statin therapy in particular. The learning objectives that I have is to talk about our guidelines that we have, or I should say our scientific statement, which addresses statin intolerance, also the evidence that supports a nocebo effect. I think all clinicians that are interested in lipid therapy, especially those that prescribe statin therapy, should know about this, and really summarize some strategies that can be used for patients that have suspected statin intolerance. I think I don't really need to convince this crowd of the importance of why we're here, but cardiovascular disease, just as a lead-in, remains the #1 cause of mortality in the United States. And census data shows that when we project all the way out to 2060, which is 40 years in the future, that risk factors such as diabetes, hypertension, obesity, dyslipidemia are going to continue to grow. So it makes treatment of hypercholesterolemia, of which we use statin therapy, everybody knows that, that is highly relevant. And hypercholesterolemia is a costly disease. Over $20 billion are estimated to be required to provide health care and also to address lost productivity. We know that LDL cholesterol is the primary atherogenic lipoprotein that we target in the United States. If we were in Canada, it would be ApoB, but we do value targeting LDL cholesterol as our primary treatment strategy to manage hypercholesterolemia. And there's a whole bunch of opportunity with millions of Americans having what most people would consider unacceptably high levels of LDL cholesterol. Everybody is familiar with our lipid guidelines, and I do like calling these the AHA-ACC multi-society guidelines because we're part of the multi-society being the National Lipid Association. And really this course framework of which patients are in a statin benefit group has not really changed for the past decade. We have 4 statin benefit groups, secondary prevention, and then 3 primary prevention groups. But the long history of evidence that we have with statin therapy will never go away. I used to make the analogy that, statin therapy is like metformin is to type 2 diabetes. That landscape is maybe a little bit different. I feel more confident saying that we'll never get away from statin therapies as our first line options for patients with hypercholesterolemia for a variety of reasons. Mostly because they're good and proven at reducing LDL cholesterol and cardiovascular outcomes. But as we sort of push to lower LDL targets and therapeutic objectives to achieve, we need more than one drug. We sort of adapted that this is a combination therapy condition. And even in 2022, the expert consensus decision pathway, which was produced and published by ACC, really emphasizes the importance of LDL cholesterol. We would love it if LDL cholesterol was a quality metric again. We're going to continue that fight with ACC to actually get it recognized formally. But the expert consensus decision pathway that was published just a year and a half ago really did highlight the importance of measuring LDL cholesterol, getting it to an acceptable threshold, and also to, let's not forget, achieve the percent reduction. Now, the percent reduction is one thing, but I think where we're really challenged with, if you go through this pathway, it really is directing us to look at the thresholds. And everybody is probably aware that these are going lower and lower. So now we very much embrace treating patients to an LDL cholesterol less than 55 if they're very high risk secondary prevention, and most lipidologists would apply that to every secondary prevention patient. But we're also seeing less than 70 or less than 100 advocated for many of the other benefit groups, depending on what their individual risk situation is. So because of these lower LDL values, we need the power of not only statin therapy, but other things. So statin therapy is always going to be part of our cocktail. Maybe the better analogy is statin therapy is almost as like a thiazide diuretic is to hypertension. It's part of the package that helps get people controlled. Now, we're not doing great. I don't like to preach to the choir, but I'll take the opportunity to do so. We know statins are very effective, but there's a problem with getting them implemented in practice. And I'm not going to point my fingers at clinicians. I don't think clinicians are the sole source of why we have these data. There's a variety of factors. It's probably not cost, but it's probably largely on the patient's perspective and what they think about statin therapy. But nonetheless, we have data from multiple sources. There's just two that I like referring to. One is a publication from 2022 from Nelson and colleagues. It looked at statin use in the United States amongst ASCVD patients. It was a huge population that they had almost over 600,000 patients, and almost 50%, 1 in 2 were not on statin therapy. And those that were on statin therapy, half were high intensity, another half were a lower than high intensity amount, which really says that we need a little bit more momentum.
I'm going to apply for other jobs.
Is everybody muted?
Yeah, perfect.
I think I can hear somebody else.
Yeah, the surgery schedule. It's okay.
I'm going to keep going, but maybe make sure everybody's. Thank you. I was going to say mute your microphone. The second source is the Pinnacle Registry, which, if we're familiar with this, is from outpatient cardiology practices. Over 2.5 million patients were represented here. Same old story, that patients that should be on statin therapy, the clearest candidates, those with ASCVD, about 50%, are not on lipid-lowering therapy. And even when we look at statin therapy, this data is getting a little dated. It's from 2019. The patients who were treated with statin therapy, most of them did not have LDLs that were less than 70. And if we're targeting less than 55, we know that we need statin therapy along with other strategies to further lower LDL cholesterol. So overall, we have gaps in LDL lowering. When I said I don't want to put all the blame on clinicians, I'm not going to, because it's not always lack of prescribing. Sometimes it's lack of persistence with therapy. We have a whole bunch of different options. There's 7 different statins, and 6 of them are affordable generic options. So cost really should not be an issue for our patients. But sometimes we have, patients that fall short. It's predicted that they may get a 50% reduction, but they don't get a 50% reduction because of a variety of interpatient variability factors. But probably the thing that, in my opinion, might be one of the biggest limitations is the perception or realization of side effects. And this is mostly, but not exclusively, statin-associated muscle symptoms. So I'd like to take a little time out and have people think about what these terms mean to you. As somebody who's a lipid lover, if you're here at Neil Nights, I assume that you are. When you hear the term statin intolerant, what does that really mean to you? I think if you challenge yourself on what your definition is, think about what your colleague's definition is, or maybe what a patient's definition is, or somebody in a different practice. And I think what you might get is that there's a lot of variability in this term. And statin intolerant, some people may think actually it's, that you don't respond to statin therapy, where other people would think it's, lack of tolerability. And maybe does it require 1 statin or 2 statins, the lowest possible dose, trying multiple strategies. All those things are variables that we need to consider when we use that label. And also, what would you want to see to make that assessment? What, as a clinician, before you thought of, quote, labeling somebody as statin intolerant, what would you want to see in their profile or their previous history or their previous exposure to medicines to make you confident to use that term? Or maybe you choose not even to use that term at all because you don't like it, but you may still be in the situation where you have to deal with patients that don't accept statin therapy for one reason or another. Now, the traditional definition of statin intolerance, I find this interesting. If you go into literature, there's a lot of background noise here, but you can find sort of a well-cited publication from 2015, which gave a very broad definition of statin intolerance. And it says it's the occurrence of either adverse symptoms, which makes sense because intolerance sometimes relates to side effects, either perceived by the patient to be unacceptable, or lab abnormalities, whether it be an elevated creatine kinase value or maybe even elevated liver function tests that lead the patient to not tolerate their therapy. And I think this sort of was one of the original definitions that was quite broad. If we look to better defined definitions, there's three that I think have a lot of credibility. One is our traditional NLA definition, one is from the International Lipid Expert Panel, one is from the European Atherosclerosis Society, and they all had their own little twists. Now, this original NLA definition was not the most recent one. It comes from a publication in 2014, and it really focused on adverse effects that lead the clinician to stop therapy. The International Lipid Expert Panel, their definition was the inability to tolerate a statin. So tolerability, instead of using the word adverse effects, the tolerability side from your patient. And the European Atherosclerosis Society really focused in on muscle symptoms as part of their core definition. So maybe some unified themes within these different definitions, but a lot of individual sort of tangents that lead to different outcomes as far as labeling somebody who is being statin intolerant or not. Now, before I go to what our 2022 NLA definition is, I do want to share with you the findings of a pretty well-conducted meta-analysis. This looked at over 170 studies in over 4 million patients, and it was done from some of our colleagues in Europe, published in 2022. It really looked at all three of these definitions that had been in the literature, and came up that the overall prevalence, the real world prevalence of statin intolerance was about 9.1%, which is discernible. It's higher than maybe what we would see in clinical trials, randomized prospective clinical trials, which is not unheard of. Matter of fact, our lipid guidelines said that the clinical trials estimated prevalence is about 5%, but in the real world is about 10%. So it sort of falls in line there. They identified some risk factors for patients that, if present, increase their risk of having or experiencing statin intolerance. So it's a very useful publication to put it into perspective. It was considered when the NLA produced their scientific statement. From one of our colleagues, Dr. Mary Catherine Sheely, led this effort along with some other people. I was fortunate enough to be part of this group. When we looked at all the data available and looked at our previous definition and looked at how maybe statin intolerance was incorporated into outcomes trials, we came up with this unified definition. This is NLA policy, that statin intolerance, according to the NLA definition, the scientific statement, is that it's defined as one or more adverse effects associated with statin therapy. But the key here is that that adverse effect either resolves or improves with stopping the statin or dose reduction. And so that's important, that it's not just relying upon a patient reporting intolerance. There has to be some change with changing the statin. And if you look at other parts of this definition, it really is for the patients that can tolerate a little bit of a statin, that they don't achieve their therapeutic outcomes or the desired amount of LDL lowering. So that's important. To further codify this definition based on that core definition is really to alert clinicians that don't label somebody as statin intolerant unless they've actually experienced this with 2 different statins, one of which would be at the lowest FDA approved daily dosage. So for example, that might be 40 milligrams of pravastatin or 20 milligrams of simvastatin, or even for atorvastatin, 10 milligrams. I put that one in there. With this definition too, there's sort of 2 different types of patients: complete statin intolerance, which is tolerating 0 milligrams, or partial statin intolerance, which is a lower amount that does not achieve the therapeutic outcome for your patient. So we hope that this definition can provide some clarity and maybe be useful for research so that we have a little bit more homogeneity in data that we look at when we evaluate statin intolerance. Part of the scientific statement is some recommendations, and there's 6 core recommendations. And I know this is small font, but I really would just want to use it to call out one in particular. When the scientific statement group got together and looked at all this data, there's recommendations about, about prevalence, but the one that I want to talk about in particular is this recommendation that for patients with statin intolerance, it's reasonable to consider the nocebo effect as a possible cause. There's a little bit more to that definition, but what really jumps out is this is based on A-level evidence. It's a 2A recommendation, but A-level evidence. So this is not just a one and done from one particular study. This has been reproduced in more than one body of evidence. So that's important. A recommendation that, hey, you know, the nocebo effect may be the causative factor. And it makes us question what exactly is the nocebo effect. And this comes from actually the cancer literature. If you really dig deep, that's where they first coined this nocebo effect. And it really is a situation where a patient develops side effects or symptoms that can occur with drug therapy because it's known to occur with drug therapy, but it really is because the patient believes that it can occur. It's not necessarily from the drug itself. I call it true unrelated. True, the patient's on a statin. True, they're experiencing a statin-associated side effects, but they could be unrelated. And if that's happening, that is termed the nocebo effect. And it really comes from Latin. In pharmacy school, they made us learn some Latin to interpret SIGs. And now it's a dead language, so I don't know why we even bothered with that. But this nocebo comes from Latin, which means I shall harm, which is the opposite of placebo, which means I shall please. So we're very familiar with the placebo effect. The nocebo effect's the opposite. Patients experience side effects just because they have it in their engineered or predisposed. Their bias is that they may experience a side effect. Maybe it's because of some of the information we give them in the pharmacy or what they read on the internet or what they hear from people. One little polling question I have for you, and people you can put this in the chat if you want, or think about it. And if you put it in the chat, maybe we all can see it. I'm going to ask you this question. Polling question number 1, evidence suggests that what percentage of reported statin-associated side effects are likely from the nocebo effect? Do you think that prevalence is less than 20%, 30 to 40%, 50 to 70%, or up to 90%? And I'm trying to see if anybody wants to share what they think. I might not be able to see it in my chat, but what kind of responses are we getting? Can you see any of them, Rhoda? Yes or no? Oh, I see one response. Thank you, Michael. Michael answered 3, not to call anybody out in particular. He's a brave soul. Other people, I see a 1. Oh, Mercedes, nice to see you here. A 3. Okay, let's see, we'll maybe get some more. 2. What I'm not seeing is 4, so nobody wants to answer 4, but guess what? The answer is 4. That's shocking, up to 90%. That's pretty high amount. Usually when you see a polling question like this, the most extreme number is not the right one, but for this case it is. But let me show you where that is coming from, and it's in the scientific statement. Part of it comes from the Samson trial, which I love this study. It's an N of 1 trial. What is an N of 1 trial? It means that each person's their own control, and they get exposed to all the treatment arms. So what's the deal with the Samson trial? I don't know how they recruited patients, but there were 60 patients who had abandoned statin therapy in the past and had no intentions of going back on a statin for whatever reason. Now, they all said their symptoms rising within 2 weeks of use. What they did is they enrolled these 60 patients in this multiple crossover 3-arm double-blind placebo-controlled trial, and they gave them 3 different treatments. And each patient were treated for 12 months. They got a bottle for each month within the year. 4 bottles for 4 months contained atorvastatin 20. 4 bottles contained placebos that look like atorvastatin, and 4 bottles were empty. That's called the nil treatment. What's interesting about this is patients know when they're on nothing, but they don't know when they're on atorvastatin or placebo. So keep that in mind. Now, patients were instructed on their phone. So everybody had a phone, and they logged on a scale of 0 to 100 their daily muscle symptoms. So 100 being the worst imaginable, 0 being nothing. Who were these people? They were about 66 years of age, a good split of males to females, but mostly white people. So that's maybe not the best representation of our population. But look at the number of statins that these patients have been exposed to prior use, at least 2 or more for most of these patients. And their prior duration of how far back they had been on statin therapy was almost 3 years. So some of these people had been well in the past that they've abandoned their statin therapy. Well, here's what happened. If you look at the average symptom score on the left here, with no treatment, meaning the nil treatment, it was 8, but it was 15.4 placebo, which is just one little bit shy of the 16.3 that was reported with statin therapy. Look at the gap between no treatment and placebo. That is a 90% difference between no treatment and statin. So 90% of the net overall difference was attributed to the nocebo effect. People who were swallowing a pill experienced muscle side effects because they knew it was possible. When they knew they were taking nothing, the scores were lower. Now, I don't want to say that when I've given this presentation before and explained these data, and people say, oh, Saseen doesn't believe that there's statin-associated muscle side effects. That is not true. I believe patients can have muscle side effects. I do, from a statin. It's just that I believe that it's over-exaggerated. And the data indicate 90% difference is the gap. When you look at, and I can say that confidently, when you look at the right, here's some data of people who had to stop their therapy. And you see a lot of patients when you compare placebo to statin, that even though this wasn't statistically significant, there was a trend, there was only 60 people in this study, that people on statin therapy had a higher rate or a sooner rate of stopping therapy. So that implies there's something there, it's just over-exaggerated. This 90% gap is a nocebo effect. And patients, if you look at what's plotted here on the left, is in red is the statin data per month, in blue is placebo data per month, and the open bubble, the white bubble, is no treatment. This is their average score per month, and it's all over the place. Patients had symptoms that were ever present, meaning they had symptoms with everything. Some people had successful rechallenge where they had, symptoms with statin 1 month and then none the next, or less the next time. And then some people had this clear nocebo effect where when you compared no treatment to just a placebo, there's a big difference in gap. So this was pretty much across the board. Now, another bit of data I want to lean into is that supports this nocebo effect is the unfortunate situation in the United States. This was published in Circ Outcomes, Quality Outcomes, which is a reputable journal. It was an evaluation of FDA data and then some European data. They looked at almost 3 million reported statin side effects. And these come from the FDA's adverse event reporting system, which is voluntary and it's not objectively confirmed, and it's not peer reviewed either. So these are just reports that the FDA receives about side effects. They looked at data from 2010 to 2019, and on the left is basically side effect reports with statins. And the blue line are subjective reports, and then the dotted orange line are objective reports. So we see a big gap that most of the reports of statin-associated side effects received by the FDA are subjective. So that leans into and is consistent with the nocebo effect, that it wasn't confirmed with a biomarker change. And this could include some other side effects beyond muscle. But look at the non-US data, and I find this intriguing. When you compare the same kind of thing, subjective versus objective side effects reported with statin therapy from European databases, we see that, there's less of a gap. What does this tell us? In the United States, we're more willing to talk about our side effects, and we're more willing to report subjective side effects. So maybe this is part of our culture or some reason, but it sort of also supports overall, in general, this concept and what I think is a proven effect, which is the nocebo effect. There's even data from the cholesterol treatment trialist collaboration, which actually came up with about a 90% nocebo effect. Excuse me. Now, what are these data I'm sharing with you? These are 19 double-blind trials of statin versus placebo. And then there were some 4 double-blind trials that looked at high-dose statin versus a lower dose of a statin, and good numbers of patients here. And we know that cholesterol treatment trialist collaboration does things the right way, at least in my opinion, they do. And when they looked at the reporting of muscle pain or weakness, we see that, people on placebo have a lot of muscle pain and weakness, and it's only slightly higher when they're on a statin. And you look at those numbers, they're very close to one another. There is a statistically higher rate with statin versus placebo and high statin versus lower statin. So there is a difference between treatments. But if you look at the gap, they estimated also that the nocebo effect explained about 90% of the reported side effects. So that's some of the reality that we have to live with in the United States. Now, what can we use to help us as clinicians now that we know what the definition of statin intolerance is according to the National Lipid Association? We also know what the nocebo effect is, and that it's up to 90%. We do have some guidance that was published in a second publication by the National Lipid Association. This is the NLA's SAMS, or statin-associated muscle symptoms clinical perspective. And people agree with many of these things. There's a little pushback on some of these recommendations, but these are clinician-focused recommendations on what strategies you can use when you have a patient who has statin-associated muscle symptoms, which is the primary cause of statin intolerance, or the primary, side effect associated with statin intolerance. Some of the things that we can think about that have some support in the literature is using a lower dose of the same statin, we know that we do that all the time, lower the dose, and sometimes the side effect goes away. Switching statins from, you can go from a lipophilic statin to a hydrophilic statin. Heck, you can even do the opposite if you want, because I'm not sure that's always foolproof, but that's one strategy that we use. We use evidence-based strategies such as looking into literature and sometimes using things like intermittent dosing of statins, even though that's off FDA label, of using maybe a long half-life statin once, twice, or 3 times a week. There's this in the recommendation number 4, let me explain it, and it's maybe using naturally derived statins. I would only consider this strategy probably plausible for a patient that doesn't like the idea of a synthetic drug. If they have in their head, oh, I like the natural approach, we can use naturally derived statins, which are simvastatin, pravastatin, and lovastatin. I don't love lovastatin because of drug interactions, but that may resonate with some patients. A little bit of a statin is better than none, and using the lowest milligram strength there. Now, what is advocated in this clinical perspective to avoid are things like supplementation. They believe it's unproven. There's back and forth data with coenzyme Q10. I know I always get people that still believe in it, and I don't think it hurts. I don't necessarily count on it, and there's some data that show that it works, and there's some other data that is probably more well designed that shows it doesn't have a real effect on minimizing or treating statin-associated muscle symptoms. So that's overall considered unproven according to the NLA's clinical perspective, and using other nutraceuticals to treat or manage or prevent statin-associated muscle symptoms. If you're interested in a little infographic, this 2-pager, you can print it off and you can actually have it in your clinic if you want for future reference and use. There's even an algorithm, and this is a very skinny version of the algorithm. If you're interested, you can get these slides and print off a big picture of this. This is my thinning out of it just to make it a little bit more functional for me personally. It's an algorithm for how to step a patient through the management of statin-associated muscle symptoms. And a few things I just want to call out. You don't always have to check a creatine kinase level in a patient with statin-associated muscle symptoms. Consider checking it when patients report either moderate or severe symptoms. If it's mild symptoms, I don't always feel the need to check a creatine kinase. If I suspect a drug-drug interaction, I may do it. But that's one thing that jumps out here, and there's guidance. If it's greater than 5 to 10 times the upper limit of normal, that's when you should seek care, have a patient seek care, and maybe rule out rhabdomyolysis under that circumstance. Look for underlying causes. Something that's very, very apparent, though, when you're working up a patient is to rule out secondary causes. And what do they say in the medical world? Common things are common, right? Don't look for zebras always. And what's one of the most common causes of statin-associated muscle symptoms? Well, sometimes when patients start a statin, they change their lifestyle, and they may become from less sedentary to more sedentary. We know that. And if you haven't used your muscles in a while, and it hurts when you start using them, it may not be the drug, it may just be increased physical activity. Let's not underestimate the power of when patients are taking a medicine. If they're properly educated and motivated, they may actually really try those lifestyle modifications. And that may be an explanation for statin-associated muscle symptoms. There's other recommendations about encouraging statin continuation, re-challenge, using different doses, so on and so forth. So use this to your advantage if it helps you with patient care. A few things, since I'm a nerdy pharmacist, to keep in mind. I think always comparing the different statins to each other is important. I mentioned lipophilicity, switching from a lipophilic to a hydrophilic statin. How do we actually get that terminology? Well, it's all based on the log P ratio of the drug. And log P is sort of how much a drug partitions into fat tissue. So any log P value that's associated with a statin that is 1.0 or higher, 1.0 is neutral, but higher than 1 implies that it partitions into fat more than into water. So it'll be labeled as lipophilic. So we see that drugs like lovastatin, simvastatin, and even atorvastatin are considered lipophilic, whereas rosuvastatin or pravastatin in the negatives here are considered hydrophilic, and pitavastatin somewhere in the middle, sort of close to that neutral effect. There's also drug interactions that are present with statins. Lots of them are attributed to the changes in the CYP system, whether it's the CYP3A4 or the 2C9, depending on which statin is available. Some patients may have poor kidney function and may accumulate statins. For example, if you look at a drug like pravastatin or even rosuvastatin can get you in trouble too for patients who have G4 or G5 chronic kidney disease, because you may have to dose restrict to avoid drug accumulation under that situation. If you're ever worried about kidney impairment, I always go with atorvastatin since it relies the least on renal elimination. And then we also have the half-life here in case if you want to do intermittent statin dosing, which is off-label. There are 3 statins which have long half-lives of more than 10 hours, which would support that particular off-label dosing strategy. There's also, besides drug interactions that affect the CYP system, there's also a whole bunch of other transporters like P-glycoprotein, the breast cancer resistance protein, and also the OATP, which is the organic anion transporting polypeptide. These basically, if you look to this picture on the right, this is adaptation from the Journal of Clinical Pathology, one of their publications. When we swallow a statin, we absorb it, and it goes through a lot of metabolic changes where it gets absorbed, it goes through the liver, you have some excretion through the bile, we have some biotransformation for a lot of these particular statins, but there's a lot of different steps, and there are some transporters that move the statin from one part of the body to another, and some drugs can block that translocation and result in a drug-drug interaction. Now, it doesn't always, drug-drug interaction usually causes harm. It causes an increased risk of side effects. It doesn't always lead to more efficacy like we might think. So we try to avoid drug-drug interactions if possible. And there are a lot of different statins that are subject to OATP transporters or P-glycoprotein or the breast cancer resistance protein. I have to look up individually, and when I enter into EPIC, a combination, if it gives me an alert, I read that alert to see if there's a real drug interaction that's reported or not. I do want to comment on intermittent statin dosing. I already mentioned, I do want to emphasize again, because this is for C, it's off-label, but there is data to support the use of intermittent statin dosing. There's a systematic review that looked at 10 different studies, and it really, maybe we have everybody mute. Thank you. These 10 studies looked at a small number of patients, but it was almost 600 patients with prior SAMs, and really established that drugs like atorvastatin or rosuvastatin, when used once, twice, or 3 times a day, while they may not lower LDL like a high-intensity statin, it will provide some LDL lowering, and a lot of patients who had previous statin intolerance may tolerate this option. About 70% were able to tolerate intermittent statin dosing versus no statin at all. So I think there's some data to support this, but again, that is off-label, and it's not my first preferred approach to managing statin-associated muscle symptoms. We may have to go, and we know this is reality, and especially considering, the lower LDL values that are recommended by the ACC expert consensus decision pathway, and even the European guidelines recommend lower LDL values too. We have to dip into non-statins, either to augment the effects of a lower dose statin in your patients with statin intolerance, or as an alternative. And we see there's a lot of different options available. Some of them are oral, some of them are injectable. We have everything from ezetimibe, which is a cholesterol absorption inhibitor, to the PCSK9 modulators, whether they're antibodies or they're small interfering RNA therapy. And we even have bempedoic acid as an oral option too. They're all a little bit different in their potency. We know that the PCSK9 drugs are pretty good. They can lower LDL cholesterol 50%, maybe even more, depending on which product you use, where some of our oral options like ezetimibe and bempedoic acid give very modest reductions in LDL cholesterol. Better than nothing, but available there. I want to move on to another polling question, number 2. And so you can, if you're confident enough, you can put this into the chat. But my question for you is, which of the following non-statins has been shown to reduce cardiovascular events in patients that are statin intolerant? Is that non-statin bempedoic acid? Is it evolocumab? Is it ezetimibe? Or is it inclisiran? So basically, which one of these has outcomes data exclusively in the statin intolerant population? Let's see. This one might be a home run. I see a lot of people answering 1, and somebody's spelling it out. Yeah, the answer is 1. So yeah, this is not a trick question. Evolocumab has data in combination with a statin in very high-risk patients, absolutely, from the Fourier trial. And ezetimibe does too from the IMPROVE-IT trial, modest reduction. But bempedoic acid has its outcome study in a statin-intolerant population. And for those of you who need a little refresher on bempedoic acid, what is it? It was approved right before the pandemic. It is an ATP citrate lyase inhibitor. And if you're thinking, where is that ATP citrate lyase useful? It's in the liver. As a matter of fact, it's the top of the HMG-CoA reductase pathway, where citrate gets converted to acetyl-CoA, and that starts the HMG-CoA reductase pathway where we target statin therapy, and that's where it works. This works in the liver. So bempedoic acid is a prodrug. It gets cleaved or bioactivated by an enzyme that's only found in the liver to go into its active form, where it blocks conversion of citrate to acetyl-CoA. So your body has a lesser ability to make cholesterol. There's also an increase in LDL clearance receptors that have been demonstrated with this drug too. It's an oral option option. It has some side effects such as hyperuricemia that have been reported, and some other ones that are listed in this slide. Some drug interactions with simvastatin and pravastatin that we need to consider. No contraindications on label currently right now, but it is a drug that is approved for LDL lowering, ideally in combination with maximally tolerated statin therapy in either secondary prevention patients or those with familial hypercholesterolemia. Now, the outcome study, which we've all heard about, if you went to ACC last year, they blasted this. It was on buses going by saying, oh, release the CLEAR outcome study. And it was released there, just, was it 10 months ago now? And the CLEAR outcomes, as a refresher, was a double-blind placebo-controlled trial in almost 14,000 patients, all of which who had statin intolerance. These patients were a mixture of secondary and primary prevention. 23% were partially statin intolerant, meaning they were on a low dose of a statin, and the other 77% were completely statin intolerant, meaning zero statin. They looked at the primary cardiovascular endpoint, which was CV death, non-fatal MI, non-fatal stroke, and coronary revascularization, so a 4-point MACE there. These patients were about 66 years of age with a starting LDL of about 140 milligrams per deciliter. And after a median of almost 41 months, there was a significant reduction in the primary endpoint. It was reduced significantly. That p-value we see listed up there. The placebo group had an incidence of the endpoint of 13.3% down to 11.7 in the bempedoic acid patients. That number needed to treat is about in the 60s. So it was an impressive reduction in cardiovascular events for the 4-point MACE. One thing, if you really dive into this too, I do want to talk a little bit about this. If you look at who drove the results, there was a difference between secondary prevention and primary prevention, and I was not expecting this. But primary prevention patients, this is a subgroup analysis, really drove the results. We see this if you go into the appendix, the supplementary appendix, that the hazards ratio for the endpoint was 0.68 with primary prevention, and it was significant versus only 0.91, which wasn't significant in secondary prevention. It was front-loaded. There was more secondary prevention patients than primary prevention patients. So not expected that the primary prevention population would perform so well, but they did. This is a subgroup analysis, and we should look at the collective population, but I found that intriguing. And it was intriguing enough that Steve Nissen, the PI of this trial, actually published in JAMA secondary analysis of just the primary prevention patients. And you can see the breakdown of these patients, their age. It was more women than men, which is great to see in a clinical trial. These patients clearly had cardiovascular risk, even though they were primary prevention. But look at not only the 4-point MACE results, which this specific subgroup analysis came up with a 0.7 hazard ratio, which is about 30% risk reduction. They also demonstrated, even though this is subgroup analysis, not a pre-planned analysis of the subgroup analysis, they showed a reduction in all-cause mortality. So there's something there in primary prevention that they especially resonated. Now, there may be some explanations, maybe some study flaws where one group, maybe the secondary prevention patients had more drop-ins with statin therapy. I haven't seen the clearest explanation of why, but it is intriguing to me. Maybe, a secondary prevention didn't lower the LDL enough, because remember, they started about 140, and maybe, getting down to the low 100s improves primary prevention, but to really reduce secondary prevention the best, maybe need to go lower. I'm extrapolating a little bit, but the data are what they are, and this is what we have. There's also, I do want to talk a little bit about what else we can do for patients who have statin problems and statin intolerance. One thing I don't want to get away from is sort of like, don't give up on your patients, especially ones that are willing to try another statin. And I say that with confidence because we have some data to support this. This comes from the STATE survey, which was sponsored by the National Lipid Association. It was a survey of 1,500 patients who had self-reported hypercholesterolemia and who had taken at least statin therapy over the past year and had one experience of statin-associated muscle symptoms or statin-associated adverse effects in the past 6 months. Now, why do I even have this to share with you? I really want to emphasize that a lot of people, over 40%, tried 2 or more statins, but what jumps out at me is almost 78% of these patients who had experienced statin-associated symptoms in the past 6 months were still on their statin. And why is that? Why were these patients that had a side effect still taking their statin? Well, the ones that stick with it are because they realize the benefits. And it's, if you look at that middle box there, it says they continued statin therapy to avoid a heart attack or stroke, for cholesterol lowering, and or because their provider recommended it. So, sometimes patients may have some mild symptoms that we still can treat through. Don't give up on it, and give patients confidence of the long-term benefits. I think this is some data that does work for a lot of people. In the clinical perspective that we have also, there are some recommendations on how to improve persistence with statin therapy. And persistence is staying on the drug long term, which is that's a form of adherence. Adherence has primary and secondary adherence and non-adherence associated with it, but persistence is really the key to get the long-term benefits. There's things that we can do as clinicians, such as use respectful inquiry, asking patients about side effects in an appropriate way, in a respectful way versus sort of an accusatory way or an expecting way. Providing positive verbal reinforcement for patients when they are, taking their statin therapy or had behavioral change is always very important. Using shared decision-making, especially when patients are running into problems, given more than one option. Hey, we can decrease the dose of your statin and see how your LDL responds, or maybe we can switch you to a different statin. There's maybe 2 options that we have for you. Give your opinion on the different options. I think giving more than one thing and having the patient engage in that decision is the essence of shared decision making. And even if it's negotiating for a drug holiday to see how patients perform after that drug holiday and if their side effects go away, if that's the situation that you have. Another thing I do want to talk about, since we talk a lot about the patient-clinician relationship, and heck, in our wonderful 2018 guidelines, a Class 1A recommendation is to have a patient-clinician discussion about therapy. And I look at that and I endorse it, but I have to laugh because it seems silly. Why do we have to make a recommendation that a clinician and a patient to talk and discuss therapy? It should be implicit, but I think we need to be reminded that that's very important. And it may actually help with the human factor of the relationship between your patient and the clinician. And what we ideally want is to have a trusting relationship between the patient and the clinician. But I found some of this literature interesting, and it talked about trust and distrust. So trust is when caring meets competence, and distrust is using a validated medical mistrust index can actually occur when there is some imbalance between competence and caring. So I want to take your attention to the right part of this slide. And if you look, how do we achieve trust with our patient? It's when you come off as a clinician as both caring and with high confidence. That leads to trust from the patient and the perspective of the clinician. You could have just respect, where you come off with high confidence but not caring. The patient will respect you, but they may not trust you. You can have distrust, which is low on competence and caring, or you could have what is considered affection, where the patient really thinks you care about them, but they don't think you're all that competent. That's unfortunate, and I find that there are a cohort of patients out there that will go to a clinician that they don't necessarily completely trust because they feel, oh, they're just so nice to me, or I feel comfortable with them. And that's, maybe better than nothing, but I think let's strive for trust by exuding both caring and competence at the same time if possible, especially with side effects. The ugly truth with statins sometimes comes down to this, and this is my definition. It's a personal definition, and it's called statin defiance. And this is what I define as that patient who demonstrates open resistance or refusing to accept statin therapy despite logic or evidence. And it really is due to either disinformation or misinformation about statin therapy risks and benefits. I incur this a lot. And it's frustrating. And I think it's escalated with a lot of things that have happened with distrust of the medical system throughout COVID for people that, for a variety of different reasons I don't want to go into. But I think we've all experienced this. Just that patient that says, nope, I'm not doing it. And it's for an illogical reason. And, what is dis and misinformation? I think we have to remind ourselves there's some definitions from the Health and Human Services Division of the government. Misinformation is what I call unfortunate. It's that patients have false or inaccurate or misleading information. And, that's sort of a missed opportunity. They just got it wrong. But disinformation pisses me off. This is what irritates me because disinformation is malicious. It's information that maliciously is spread for either financial gain or political gain. And we can make a lot of, correlations between this and other things. But, some people out there just have it out for statins and they want to make themselves vocal. They want other people not to use statins for whatever twisted reason. And that is disinformation. Both of them are not good, but disinformation is just sort of, a little bit criminal, to my opinion. And why is this? Well, if you look, throughout the world, we now have what was called an infodemic. We have a lot of information. You can get it a variety of different ways, and a lot of it is medical information. But unfortunately, some of it is misinformation, whether it's just unfortunate misinformation or disinformation fall into that big bucket. So that's the reality that we have right now. We even have some data that what's in
based on, I'm not a social media person. I admit it. I know that some ways I should be, but I just don't like social media. And this data made me feel better about it. This study, which was published in JAMA, actually looked at basically social media posts related to statin discussions. And they looked at a lot of them. There was over 10,000 unique statin related discussions. Some of them were posts, some of them were comments on posts that were out there in social media. Now, there were themes to this, and you see there were 100 different topics identified, everything from the ketogenic diet. So, Dr. Out there, there's a lot of our different colleagues that would really, this would resonate with them. But there's things like statin hesitancy, red yeast rice. The thing that jumped out at me when I looked at this, I wasn't surprised by any of this, but if you looked at, overall, 2/3 of the discussions were neutral about statin therapy, and almost 31% were negative in their sentiment. Very few were positive to statin therapy. So this is the battle that we have as clinicians when we're prescribing statin therapy. I want to wrap this up with a little bit of just polling questions to just, see if we have some interaction here. I want to show you patient A and patient B. So patient A is a 60-year-old secondary prevention patient with an LDL of 120 at baseline. Patient A, the secondary prevention patient, had intolerable myalgia with both atorvastatin 80 and rosuvastatin 40, and their CK values were always normal. So that's one patient that we have. Then we have patient B, a 55-year-old primary prevention patient who's higher risk because they have diabetes, hypertension, and they smoke. Their LDL baseline is a little higher, it's 145, and they had intolerable myalgia with 3 different doses of atorvastatin as low as 10 milligrams. They have it even with rosuvastatin 5 and pravastatin 40, and their CK values are normal too. Maybe you can imagine seeing patient A and patient B in your practice. My question for you, polling question number 3, is which one meets the definition by the NLA as statin intolerance? Is it neither patient, both patient, A or B? And I'll go back to them again. So neither, both, A or B. Which one would you label as fitting the NLA definition of statin intolerance? Now, they both appear to have statin issues, right? And I'm seeing some people are saying, I see both patients. Now, the only thing I have issue with, if I had to answer, this is one that I don't love this kind of question. It's very, very picky. So if you're thinking of this, the NLA definition, they both appear to have statin intolerance, but B meets that definition. A, what's wrong with A? How come they don't? They only tried the 2 highest doses of the 2 strongest statins. And I put this in there is, I wouldn't want to label patient A as statin intolerant yet because I want to go down on the statin. Now, this person on the right, patient B, they had a lot of different options. And they did try the lowest available dose of a statin. So there's a little more, I wouldn't give up hope on A and I wouldn't label them yet. I'd go down on the dose before I made that decision to the lowest approved daily dose, which is lower than those 2 that are listed there. I just wanted to throw that in there as sort of like putting that definition a little bit more into reality. The second question focuses just on patient B. And this is, maybe there's not a right answer here, but maybe it's more of an opinion poll. I want to ask the audience, which of the following would you recommend? So I'm not going to say one is right, one is wrong for patient B. Remember, they're a primary prevention patient, intolerable myalgia with, looks like 5 different statin regimens, always had normal CK values, and that baseline LDL is 145. Would you retry a statin with coenzyme Q10? Would you start bempedoic acid, start evolocumab, or start ezetimibe? And again, I'm not going to say that one answer is correct or not. I just want to sort of see what this audience's temperature is for different things. So I see 4, 2, 3, all recommended there. So what are some of the benefits here? Nobody's saying one. One's not my first go-to. If somebody's on coenzyme Q10, they say it works for them, then I guess I'm okay with it. Turn a blind eye, but I'm not going to count on it. Starting bempedoic acid, do you have outcomes data that would support that particular drug? I see somebody saying intermittent statin dosing, yeah, and I see somebody saying 4 then 3. And why would people pick 4? Well, that's reality. Ezetimibe actually is a very affordable. I don't have to fill out a prior authorization for that. I'd love to get 3 on board because, this patient is pretty high risk, but I don't know if any insurer will cover evolocumab. I wanted to throw this out there. I think you can justify any of these options, and maybe it's in a tiered order where, some clinicians may have had good experience with coenzyme Q10, so they go to that. The patient has tried 3 statins, and I got something from Ann Liebskind once. She said she was describing a patient with statin intolerance that had tried 5 different statins in the past. And she said, sometimes everybody says, ooh, I don't want to deal with that patient. But somebody who's willing to try multiple regimens shows you that they're willing to try and try starting something different for their therapy. So that might be viewed as a good thing. What about patient A? Same question. What would you answer for this patient? What would you do? This is a secondary prevention patient. LDL 120 at baseline, on atorvastatin 80 and 40, both experience intolerable muscle myalgia. Intolerable means they're not on it. So what are you going to do with this patient? We got start moderate intensity statin with ezetimibe, or maybe bempedoic acid with ezetimibe, alirocumab, or inclisiran. Again, this, I'm not going to say one is right or wrong per se, because I think you can probably justify a lot of these. And what's the temp? I see a 3, a 1, a 2, a lot of 1s. So 1 is moderate intensity statin with ezetimibe. Hey, you got the IMPROVE-IT trial to back that up. Why not? Why not try that? A theme here is if you use moderate intensity statin, you're probably not going to get that 120 to less than 70, or definitely not less than 55. So 2 drugs probably would be needed. Hey, on label, you can use bempedoic acid with ezetimibe too. This patient is statin intolerant. Why not? Alirocumab, I'd fill out the prior authorization. I'd fill out myself because it's a secondary prevention patient. And, some people may be saying, I don't know if they're very high risk or not. 94% of patients based on US data who are secondary prevention are categorized as very high risk. So we got that. Nobody's picking 4, which is inclisiran, probably because you would start maybe a monoclonal antibody first before going to inclisiran, or maybe you have a harder time administering that, but it is a viable option for this patient. The ones that have outcomes data though here are 1, 2, and 3 technically. Some people in the FORI and Odyssey trials were on 0 milligrams of a statin, a very small amount, but some of them were. So some of the takeaways, before, I think there might be one question in the chat that I can address too. I do want you to feel comfortable that, the term statin intolerance is a quote definition by the MNLA. I believe in that definition, but maybe it just makes the clinician think, what else can I try before applying that label? They really try the lowest daily FDA approved dose of a statin before using that term, at least one, and with one of the 2 statins. I think that I'm a believer there is a nocebo effect, and I think the evidence does show that. Not everybody wants to hear that. I do believe there's statin-associated muscle symptoms. Please don't get me wrong there, but I think that they're conflated. And there are multiple strategies for treating patients with SAMs. It's not, don't go away from statin therapy after 1 and 2. At 2, maybe you would, but I usually in my practice try more than 2 before I give it go away from statin therapy. And it does depend on the patient-clinician discussion. I do thank you very much for your attention. What I do want to say, I want to go back to one of these questions. I think Robert Block, do you provide very reliable, valid documents to patients to read? I do, as I can help them to trust less some of the social network information they see. I think that's a great point. I really like, I like that idea. I have the luxury, I have sort of bifurcated patient population where we have some very educated people that work at the university that come to the practice I'm in, and then we have some other patients who have a lower socioeconomic status and lower health literacy. I think if patients do have high health literacy, I'm happy with sharing with them some more additional information. I actually shared some clinical trials with an oncologist once. They were a patient that I believe had FH who didn't want to be on therapy. They were in their early 40s and they had a history of premature cardiovascular disease in their father, and they were reluctant to start statin therapy even though their LDL was in the 200s. So I shared with them clinical trials. So I think some reliable documents that are at the high level are appropriate. There also are some things from the National Lipid Association, the statin infographic sheet. Go to lipid.org, and if you look at some of the tear sheets, it's actually written at for patients who have average health literacy, and I think it may help some of them. And maybe some other people on this particular webinar may have some other things that they would advocate for too. So I think that's really important. Anything else I can expound on further? And we do have a reminder to complete that survey monkey for CME accredit.
I've got a question if you got a minute.
Yes.
So I have actually spoken with our research pharmacy, and I have tried to get matching placebo so that I could do an N of 1 trial with some of my participants. And I admit now that we have inclisiran and bempedoic acid, it's a little less relevant than it was maybe 5 years ago. But basically, I was told that there aren't matching placebos you know, that there aren't really that, and that's not really available. And so like, I found the Samson trial to be curious and interesting, but not applicable. I'm curious what your thoughts are on getting a pharmacist involved to do an N of 1 placebo in the clinical setting.
Yeah, I think that's very intriguing to bring that up. There may be some regulatory barriers because you would have to compound the placebo and compound the statin into a matching, you know, you'd have to basically put it with talc and into a capsule and put the pill in there or grind it down and compound it that way. You might be able to find it. I would think some research pharmacy might do it, but they probably want you to register like a clinical trial and go through the regulatory approval through the IRB. As unfortunate and paperwork intensive as that might be, I think that's interesting. I want to say that I've talked to some people at an MNLA meeting that there was one clinician that was doing that out of Canada. They did it in their own practice. They may have done it sort of like maybe not in compliance with regulations and done it on their own. Because you could, you know, some people can, I'm not advocating or recommending this, that you can actually maybe do your own compounding. I think some people have done that, even though it's not recommended by the FDA or under any regulatory authority. I wish we could do that more frequently. I wish there was a prescription placebo that we can write for, but we simply don't have that. So I think we may have to just accept the Samson data. And there's some other ones. There's Statin Wise is another trial that did a similar kind of thing. And then there's the CTT analysis. I basically do accept the placebo effect, but it's hard to explain that to patients. I will say real quickly, I was making, when the Samson trial came up, I was making a slide on a plane, I think the slide that I showed you there. And the guy sitting next to me was about a 50-year-old dude in pretty good shape from Colorado, and he's reading my slides, and he said, "Oh, that was me. I had statin-associated side effects." And I went to the next slide to show the results of the Samson, explained it to him, and he's like, "Oh." And I had to explain it in his language, and I'm like, you know, maybe you need to try another statin. Maybe it won't happen. And yeah, that's maybe one explanation that I have one success that way. I've explained the Samson trial and nocebo effect to some patients, and I do get sometimes some deer in headlights, and sometimes it does work. Sometimes they do understand that.
I'm still tempted by that idea of, you know, an N equals 1 trial. But yeah, no, I've not been able to succeed to get it. I've tried.
Well, maybe it'll come to fruition one day or another. I hope it does for you.
Okay. We're down to the minute. Dr. Saseen, thank you so much. That was excellent and so informative. I don't see any other questions, and I know we have a hard stop at 8 o'clock. So
All right. Well, thank you very much.
thank you. Be well, everyone. Thank you for joining. Don't forget to get your credits. Bye, everyone.